All right. Well, thank you everybody for joining the Lunch and Learn today. Um, as Terry introduced me, I'm Denise Wells. I'm the Executive Director of the Nursing Home Ombudsman Agency of the Bluegrass. We are a nonprofit that provides ombudsman services to Central Kentucky's long-term care residents. And we also house the state long-term care ombudsman program, providing technical assistance and support to all of the ombudsmen in Kentucky, long-term care ombudsmen in Kentucky, as well as doing a lot of systems advocacy at the state level as well as the federal level on behalf of long-term care residents. And so, as we said, today I'll kind of be going through some things to think about to decide when it might be time to consider a long-term care facility for a loved one. But first, I know many of you are in UK's system, so you might already know about the word ombudsman. Most people that we speak to have maybe never heard that term. So first, I'm going to go over what an ombudsman is, then talk a little bit about long-term care and the different levels of care, and then some signs that a loved one might need long-term care, how to choose a facility, and then how to get good care once you've gotten that person into a facility. So, as Terry said, it is a jam-packed agenda. But if you have questions, if you don't mind to pop them into the chat. As I told Terry, I am easily distracted onto a tangent. So I want to try to make sure I get all the way through the materials before I get too distracted. So first, what is an ombudsman? You all may already know that an ombudsman is an advocate. Long-term care ombudsmen, though, are really unique even from the general term of an ombudsman. Long-term care ombudsmen are resident advocates, residents being in long-term care. And in Kentucky, ombudsmen advocate for the quality of care and quality of life for residents in nursing homes, personal care homes, assisted living communities, and family care homes. And so we are authorized through the Older Americans Act to provide these services. And it's a federal program. So that means that there is a long-term care ombudsman program in every state, in Puerto Rico, in Guam, and in Washington, D.C. So there are 53 state long-term care ombudsman programs to ensure that every long-term care resident in the country has an advocate, even if they don't have a family member by their side. And so we have lots of responsibilities under the Older Americans Act. We are responsible for first and foremost making sure that residents have regular access to the program. In Central Kentucky, we make visits at least quarterly to each facility. In Central Kentucky, we have part-time staff that go almost weekly to most nursing homes. More often if there are problems. We identify, investigate, and resolve complaints made by or on behalf of residents. We in Kentucky investigated some 10,000 complaints last year on behalf of residents. We also provide information to residents and the public about long-term care services. So, this kinds of presentation, educating residents and their families about the rights that they have while they're in long-term care. We provide technical support to develop resident and family councils. That's another way that they can learn about their rights. We advocate for changes to improve their quality of care and quality of life, both on that individual level through complaint investigation or through the resident council, family council avenue. And then, as it says here, in governmental agencies before legislative avenues. We've been very active in the last few years as Kentucky has moved to, as they've said, modernize the assisted living regulations in making sure that they do so in a way that still protects long-term care residents' rights. And then we also help seek legal, administrative, and other remedies to protect residents, meaning we help connect them with legal advocate or legal representatives like attorneys when a nursing home might be trying to discharge somebody or other remedies like that. Um, as I said, ombudsmen are really unique. We are 100% resident focused. So whereas an ombudsman in the UK system is might be more of a mediary where they're kind of in the middle. Ombudsmen are fully on the resident side. So we need resident consent before sharing any information. If they come to us with a complaint, before we do anything with that complaint, we talk to them about what they would like us to do and who we can talk to and what we can say. The resident guides our actions. So if they say, um, you know, I don't want you to talk to my family about this, then we don't talk to their family. But if they say we can talk to the facility about it, then they're that's what we'll do. We seek to resolve the complaint to their satisfaction. So it may not be to what the family wants, if the family was the one to originally bring the complaint to us, but if the resident is satisfied, then that's what we're looking for. We represent resident interests, and that's not always what some people would call their best interests. Um, Residents have the right to make bad decisions the same way you and I have the right to make bad decisions. So sometimes we are at odds with what a facility might think is the right thing to do or what they think is the most safe thing to do. But when a resident checks into a nursing home, they don't check their right to take risks when they check in. Um, we empower residents and try to promote self-advocacy. So when a resident brings us a complaint, one of the first things we ask is, have you talked to anybody about this? Do you want to, would you like help in talking to somebody about this? Do you want us to tell you who to talk to or what you might want to say to address this before we jump into trying to solve the complaint for them, to try to give somebody the tools to address those complaints themselves, because it's not a one and done kind of deal most of the time. Some of the things that we're not a licensing or regulatory body. We know about regulations and we can use them as a tool to say to a facility, hey, you have to provide person-centered care. You have to follow a care plan. You have said these are the things you're going to do and you're not doing them, and the resident is upset about it. But we're not in there citing a facility. We're not fining a facility if they don't do that. We can work with the licensing and regulatory agency, which in Kentucky is the Office of Inspector General, but only with resident consent. And then we don't provide direct care. Obviously, our job is not to go in and fill the gap of what a nursing home is doing and what they are supposed to do. It's to hold them accountable for providing the care that they are supposed to provide. We do provide staff training about resident rights or elder abuse, but we don't help residents eat. We don't take residents to the toilet, things of that nature. And then we're also not adult protective services. While we can investigate abuse and neglect or exploitation, we are not the entity that would put a perpetrator onto the registry, or who would file a report that would cause them to be charged with a crime. That would be adult protective services. And this second bullet point, we don't have the same standard of evidence requirement as Adult Protective Services or the Office of Inspector General in terms of when we are investigating a complaint. So Adult Protective Services has a very, very high threshold that they have to meet before they can cite or have a finding of abuse, because essentially they're going to file either a criminal charge against somebody or something of that nature. So they have to really meet a high threshold of evidence. Whereas the ombudsman, we're not meeting that level. So if a resident tells us that abuse occurred and we gather information that makes us believe that something did occur, we can still advocate for that resident to say, I don't want that caregiver to work with me anymore. Whereas Adult Protective Services, that's not really what they're looking at. And again, we can help a resident report that to Adult Protective Services. So that in a very, very brief nutshell is what a long-term care ombudsman is. So in Kentucky, what is long-term care? Long-term care is all of the levels of care that somebody can go into to receive basically assistance with their activities of daily living, through kind of the lens of aging and disability. This in Kentucky does not include settings like supports for community living or group homes for people who have mental illness or developmental disabilities. We are really focused on these levels of care in Kentucky. So we have skilled nursing facilities. That's and I'll go through each of these. So I'm just going to list them here. But skilled nursing facilities, which is like the top of a long-term care settings. This is like subacute after you get out of a hospital. Then you have nursing facilities, which is a step below that. Assisted living communities, which, as I mentioned briefly, just were modernized, and so those regulations changed in the last 2 years, and we're just kind of now being implemented. So they have now been broken down into three models. There's a social model, a basic health model, and a dementia care model. And like I said, I've got a slide for each of these levels. And then Kentucky still has a specialized personal care home level of care, and then family care homes. And the long-term care ombudsman serves residents in all of these settings. So, skilled nursing facilities, like I said, subacute rehab, that's obviously a medical model. There's activities, assistance with activities of daily living, but the main focus is really on physical, occupational, swallowing therapies, things like that. It's a congregate living space. It's mostly shared rooms. All of your personal services are included. All of the health services are included. These facilities are inspected every 9 to 15 months by the Office of Inspector General. And they are paid for through your stay in a skilled nursing facility is paid through primarily for most people, it's going to be through Medicare. It can also be paid through health insurance. If you were somebody who is still working, you may have a benefit that would pay for skilled nursing if you were in a car accident. Medicaid has a skilled nursing benefit. Then if you have long-term care insurance or if you have a VA benefit, it could also pay for Medicare. I'm sorry, pay for skilled nursing. Um, this is where you would go, where your loved one might go after a hospitalization, after surgery, to kind of do a lot of physical therapy to get back home. And the thing that is sometimes, I think for some people, they have this misunderstanding that Medicare pays for this for a long time. Skilled nursing is really Medicare will pay for 20 days, 100%, and then days 20 through 100, someone would have a 20% copay unless they have another either like secondary insurance or unless you have something else like a private health insurance or long-term care insurance, you may have a different setup. But so generally speaking, most people who go into the nursing home or go into a skilled nursing home on Medicare are really only there for about 2 weeks. There are ways to try to stretch that time. You can appeal the decision when you get it. If you have a loved one that goes into a nursing home with Medicare, um, but it is a short-term stay. It is not a long-term stay, even though it's technically a long-term care facility. Um, and then the one step down from that is nursing facility, which is intermediate or custodial care. And so intermediate custodial care is still a medical model. It's still assistance with activities of daily living, but it does not include those intensive therapies. It can include restorative therapy, which is like it's like trying to retain the strength that you have or the range of motion that you have. So it might be a CNA who comes in every day and helps kind of bicycle your legs so that you can continue to have that range of motion, but it's not to be able to increase the number of steps you can take. It's same as Medicare or the skilled nursing beds. It's shared living. There are some private beds in this level of care. Most of those are going to be private pay. Um, all of the personal services and health services are included in terms of like supervision, medical, or I'm sorry, medication management, um, activities of daily living, like helping somebody go to the bathroom, brush their teeth, get dressed, things like that. If somebody needs help to eat, that would be included as well. And then they are also to be inspected every 9 to 15 months by the Office of Inspector General. And in Kentucky, about 70% of residents in a nursing facility are using long-term care Medicaid to pay for their stay. You may also use long-term care insurance, private funds, a VA contract, but most people end up on Medicaid because this is such an expensive level of care. I think in Kentucky, most private pay residents are running about $10,000 a month now. When I started, it was about seven, and that was about 10 years ago. So it has really jumped up in terms of expenses. Um, in both the skilled nursing subacute and the nursing facility intermediate care, the care plan is kind of like the most important thing for somebody to look at, to participate in, to make sure that they get good care. That is a quarterly meeting, or if you're there for short-term stay, it's something that should happen within 48 hours of the person moving in. And it is basically, it's kind of like a contract between the nursing home and the resident to say, okay, these are the things that you need help with. These are your goals, and these are how we are going to help you with those things. And we we really highly encourage anybody in a long-term care setting to participate in those meetings as fully as they can, because a lot of care plan meetings are simply the social worker, the director of nursing, and maybe another staff person or two who fill it out without the resident president. They have to invite a resident. They have to invite a resident's representative if the resident has one, but a lot of people don't participate, and it's a huge missed opportunity to be part of the decision-making process in your care. And then also requesting a copy of that once you're done, or once they've written it up, is also essential to making sure that you hold them accountable for what they've said that they're going to do. So under skilled nursing and intermediate nursing is assisted living. And there are the three different types, as I mentioned. And so in Kentucky, it used to be that assisted living was simply a social model. There was no care provided. And so a lot of you who have knowledge of assisted living may know it that way. So, for instance, in Lexington, High Grove at Tate's Creek was an assisted living social model facility. They have now updated to being a basic health model. I'm sorry, my charger is giving me trouble, and I don't want to die in the middle of this presentation, so I'm just trying to make sure that I get juice back to my laptop. I think that should be okay. All right. These are assisted living communities in general are primarily private apartment style buildings. They're very swanky in most settings, especially in Lexington. They are likely to provide housekeeping. They're likely to provide some dining services, like they might have a congregate dinner, but they might not do breakfast or they might not do lunch. They should have activities, and the social model have non-professional resident assistants. So somebody that if you called up front and you asked for them to deliver dinner because you didn't want to eat in the dining room, they could bring you dinner. Residents in all, or in this, actually in all levels of assisted living must be ambulatory or mobile non-ambulatory. So that means I have to be able to walk by myself or use an assistive device by myself. So if I'm in a wheelchair, I have to be able to move myself in the wheelchair. If I use a walker, I have to be able to use the walker myself. In the social model, the idea was that you could hire an outside company to do home health with you. And this, I'm sorry, I thought I had updated this. This should say that it is inspected annually by the department, it's inspected every 2 years by the Office of Inspector General. It is all private pay as of right now. And right now, it's a lease agreement in terms of like what services you're getting in this social model. There are regulations, and you do have resident rights, but they're not providing health care. Assisted living basic health is kind of takes that original model and adds on some basic health services. So they have to provide some assistance with the activities of daily living, ADLs. Um, Again, it's the primarily private apartment style. They need to be able to provide transportation. They should provide all meals, and they have to provide activities. And then assisted living services, which is defined in the regulation. And then one of the big changes that came out of the regulation update was that they are required to have certified medication aides to assist in medication administration. And they must have a nurse available for communication at all times. Residents still must be ambulatory or mobile, non-ambulatory, and you still can use home health. And as I said before, with that previous one, it should be the same. These are to be inspected every 2 years. These are also private pay, and these are also you really have to look at the lease, and they are required to do a functional needs assessment to kind of decide which ADLs somebody needs assistance with. And then these residents also have resident rights. That's one of the things when I mentioned that long-term care ombudsmen are required to do legislative advocacy. When the bill was originally written in 2022, it was written to specifically exclude assisted living communities from having resident rights that are in state statute. And so that was one of the things that we argued was unacceptable because they were basically taking a previous level of care called personal care, and they were adapting it, renaming it, and merging it with assisted living. And so we have, thousands of residents in that personal care setting that are now in assisted living settings that would have lost rights, and then all these other residents that would have been in the same kind of level of care that would not have had those rights. So one of the great wins that we had in 2022 was that they rewrote that bill to include residents' rights for assisted living communities. And then the third assisted living community model is the dementia care model. And so they have to meet all of these requirements for the basic health model, and then plus they have to do dementia care. One of the things that is required in any dementia care, long-term care setting is that the apartment doors can't lock from the inside. Um, we're not, I don't want to get on that tangent, but it's an interesting requirement. They have to provide the same personal services and most of the same health services, but they have to give their staff specific dementia training. They have the same inspection schedule, the same payer source, and the same lease and functional needs assessment that you would want to review, and then the same resident rights. The specialized personal care homes in Kentucky, that's a model that provides care for people with residents or people with severe mental illness. These are primarily in rural communities. We have one opening up in Lexington where the gardens at Chevy Chase, or maybe that's what they used to be the villas at Chevy Chase, and I think now it's the gardens at Chevy Chase. So it's primarily a model of supervision and medication management with kind of a healthcare management. So these are primarily shared bedrooms, kind of apartment style, but um, shared bedrooms. They provide all of the same personal services, the housekeeping. They have to provide all meals. They have to provide activities. And then they have to provide health services in terms of the medication management. They will eventually have that same requirement for medication aides, certified medication aides, but they don't currently. Same requirement in terms of residents must be ambulatory or mobile non-ambulatory. These are inspected annually by the Office of Inspector General. Most residents in these facilities are paying with their state supplemental income, or I'm sorry, paying with their disability, and then they receive a state supplemental income to kind of make up for that. It's almost like a Medicaid, but it's not technically Medicaid. And then private funds can also be used. So most residents have Medicaid as their healthcare health insurance, but the Medicaid is not technically paying the nursing home, or I'm sorry, the personal care home fees for them to be there. And then finally, family care homes. Family care homes are becoming more and more rare. Most people who owned them are kind of aging out of providing care. But they essentially were really just to provide some supervision and some light assistance with activities of daily living. It's a private home with up to three individuals who need that supervision and assistance. They're required to provide all personal services. A lot of residents go to senior centers or adult day. It's a non-professional, it really is just kind of like being in a family where somebody kind of takes care of you. They're also inspected annually. Most residents, again, are on SSI or have some modest private funds to pay for that. And again, residents may have Medicaid, but Medicaid is not paying for the family care home. Sorry, you can tell I copy pasted because it's a very similar level of care in terms of how much assistance it is. But it's just a different setting. So those are the different levels of care in Kentucky. And so kind of as we went through them, you can kind of tell who might need that level of care and who might not be appropriate for that level of care. If you're thinking of a loved one and they've frequently been in the hospital and you're having to pay for somebody to be in the house with them on occasion, the assisted living might not be an appropriate place for them to go. If you're in this session today because you're thinking you might need to be looking at long-term care, assisted living might not be the best place to start because it's a very it's more of a light um assistance place to be. Um, so, but that, having that background about what these levels of care provide, how do you know that your loved one needs long-term care? So first, whenever we get somebody so I will say too, you can call our office and we can talk this through with you, on a one-on-one basis. One of the first things that we tell people though is if your loved one is hospitalized, that is an opportunity to really talk to the healthcare team while they are in the hospital about what happens when they're ready to be discharged. Many long-term care residents come directly from the hospital after they experience a healthcare crisis, whether it's having COVID, having pneumonia, falling and having an injury, having a stroke. And that hospitalization may initiate a Medicare or skilled nursing benefit period that makes it a lot easier to make it into a nursing home. So this is a critical period, a critical moment for you as a caregiver and for your loved one to talk about what comes next. Um, if your loved one is in the hospital, and it's not safe for them to return home, there's a really great packet from the Center for Medicare Advocacy that has information about kind of how to talk to the discharge planner about the discharge plan. One of the things that I find all over my life, but specifically in the healthcare setting, is there is such a disconnect between my language, my vocabulary, and the language of the discharge planner, the language of the social worker, the language of the intake, or the marketing person that's coming to the hospital to talk to me about the nursing home. There is there are lots of different ways to say the same thing, and if I'm not speaking the language that the discharge planner is speaking, they may not they may not do what I think they're doing, or they may not do what I'm asking them to do. Um, so this self-help packet has some great language for you to read and try to use when you're communicating with the discharge planner. Um, and it gives you some step-by-step things that you can do to go in and say, okay, I need, it's not safe for my loved one to return home. Uh, I'd like for you to send referrals to the nursing homes. Um, which nursing homes did you send referrals to? Which nursing homes responded? What did they say? Why didn't they accept them as a resident? And then, following up and saying, okay, well, because sometimes a hospital, depending on the social worker or discharge planner that you have, depending on the hospital that you have, we get calls, not about UK hospital, about some of our rural hospitals. We get calls from people who say, I'm 70, my husband's in the hospital, and they want me to call all these nursing homes to find a bed, and I just can't do that. Or, I'm a single mom and I work full time, and my mom's in the hospital, and I can't find somewhere for her to go, but she can't come live with me because I work full time and I have a kid, and I can't take care of her at home. So, this packet is really great for communicating with a hospital discharge planner. Um, I'm going to also say one thing here. We have heard a few stories of people who were in a hospital or had a Medicare benefit period, a skilled nursing benefit period initiated, who then went into an assisted living community and received skilled nursing there through basically in-home physical therapy. I am going to very, very strongly encourage you not to consider that. That is not only a very expensive way to get your skilled nursing benefit, um, you would be signing a lease to go into that assisted living community. Um, and you might as well just have gone home, because you're basically getting home health care in an assisted living community, because you are not getting physical therapy from the assisted living community itself. The assisted living community is not allowed to provide that level of care because that requires uh, certification and licensure from the federal government, and assisted living is licensed by a state entity. So if you hear about people doing that they're going to an assisted living community to get their physical therapy through Medicare, I would encourage them to call us and talk to us about that. We have heard of people spending $14,000 because that's what they decided to do. And if they had gone to a nursing home and they had just done 14 days or 20 days, their bill would have been $0. So just please consider that. So this is one sign. This is one reason that you might decide that it's time for a long-term care setting. Another reason, another why, or another how to decide, is looking at the changes in condition. And this is obviously really complicated. There's unfortunately not a checklist that I could give you that says, okay, here's a very clear yes, a very clear no, that somebody does or doesn't need to go into long-term care. And changes in condition are often so gradual that you might have a hard time even recognizing that there's been these changes. But number one, more frequent falling. Obviously, that can be dangerous for for your loved one. Um, if you're getting more frequent calls from the fire department because your loved one has been calling to be picked up off the floor, that could be a sign. It could also be a sign that there's something in the house that needs to be rearranged or redone. We have a coworker that is providing the primary care for his mother, and you know after one of the fire department visits, they said, You really need to rearrange. We recommend you do this, this, and this." And so he and his sister went and did that, and that's really helped a lot. So, um, you know, it may not be that it's time to move, but it may be time to really look at the layout of the house. More confusion or cognitive impairment for somebody who has dementia. Obviously, that's a big sign. Somebody who is leaving the house, getting lost, and something like that. That's obviously a really uh, big sign that that may be time for somebody to go into a setting where they can be supervised more closely. And then losing the ability to perform those activities of daily living. Um, a nursing home will be looking at how many of these activities of daily living somebody needs help with to basically decide whether Medicaid will pay for somebody to be there. Um, so once somebody needs help with so many of these things, then Medicaid would be an opportunity, it would be a payer source. And there's a lot more than what I've got listed here. But for example, somebody losing the ability to feed themselves or brush their teeth, get themselves out of bed, get themselves out of their chair, get dressed, you know, get themselves to the toilet, get off the toilet, change their incontinence brief if they're using an incontinence brief. Um, things like that. Those are all signs that they could qualify to be in a long-term care setting. And if somebody could qualify to be in a long-term care setting, then you could consider that a reason to make that move. And then, kind of in the same vein, a progression in a chronic condition. And that's another one that is a really difficult decision to make. But obviously, if your loved one has a progressive chronic condition, you may need to consider long-term care as that disease runs its course, especially as it contributes to more challenges in their daily living or as it requires more treatment. Somebody with diabetes who is no longer really able to keep their sugar under control, or it develops a wound and it isn't really appropriate for that wound to be treated at home, things like that, then that would be something that you could look at as a reason to consider long-term care. And then finally, a reason to consider long-term care is that you've exhausted all your available resources. You've called the Bluegrass Aging and Disability Resource Center. That's a great resource. The phone number is right here, or you can email them. Your loved one is enrolled in home care services, so they've got somebody doing some grocery shopping, some meal preparation, light housekeeping for you, doing some actual, on hands-on care. Um, you've got caregiver support program coming and giving some respite to you and your family, providing some products or services. My coworker is in the caregiver support program and he gets reimbursed for some of the products he purchases for his mom. You and your family have created a schedule, and you have Monday and Wednesday nights, and your sister has Tuesday and Thursday, and your brother has Friday, Saturday, and on Sundays you all go over there. Or you've hired outside caregivers, or they're in a Medicaid waiver program through the ADRC. Um, they're getting all of this support and they're still not really getting all the care they need, or you're experiencing burnout, or you're experiencing health impairments and you need additional support. Those are all legitimate reasons to consider long-term care for a loved one. Um, and as Terry said, it is a very difficult decision. And I can't tell you how many people I've talked to on the phone who cry while we're talking and make me cry while we're talking because it's so difficult. It is so difficult to decide that it's time for your mom to get help from somebody else because it's just too much. It's too much for you and your family. So there's no shame in it and there's no reason to have guilt in it, but I can't tell you that because I have the same feelings, but um, it is really difficult. In that same vein, I don't have a slide on it because I didn't know how to write it, but this can't be a decision that you make all on your own, obviously, unless you have full guardianship of your loved one. It is a discussion that you have to have together as a family or together with your loved one, because you do have to have consent of the person that you're caring for them to go into long-term care. A nursing home will not take somebody who says, I'm not going to live here. Just like an ambulance will not take somebody who says, I'm not getting in an ambulance, I'm not going to the hospital. You can work, so the best way uh, to kind of come to this decision is to talk about it before you're in this burnout health crisis yourself, to talk about it throughout the process. And I say that knowing full well that it is such an emotional topic that the conversation is not easy or pleasant. And depending on your family dynamics, it might be not very nice to have, but it is one that you have to include your loved one in. Same kind of in the hospital, with that hospital social worker, discharge planner. If your loved one says, I am not going to a nursing home, do not send my referral to a nursing home unless you're that person's guardian. That social worker will not do it then. If that person has, if your loved one has their own home, if they are in sound mind, then the discharge planner is likely going to follow their directives and send them back home. At that point, you could report somebody for self-neglect to Adult Protective Services, and Adult Protective Services can come out and kind of assess the situation and see if there's something that they can provide your loved one in terms of support or recommendations. But somebody of sound mind who is not taking the best care of themselves in Kentucky is a really difficult situation and definitely requires more discussion one-on-one. So once you've decided and you've talked to your loved one and you've come to the conclusion that you need to choose a long-term care facility, number one, you'll want to go through those different levels of care and decide, what needs your loved one has and what financial resources you have available, and kind of decide on what level of care you think might be the best for that person. Um, so then to find long-term care, we have this guide on our website. I would highly recommend you go download it. You just go to our website, ombuddy.org/publications. It's free. You don't have to give us your email address. You don't have to do anything to get it. But it has lots of information about getting into a facility, this is primarily about nursing homes, but there is a chart in the back about the long-term care settings. But it talks about how to pay for it, what Medicare and Medicaid are, that kind of thing. So it's a great resource for long-term care. And then do your research about the settings in your area. But know that Google is very misleading. This is a really old screenshot and it has improved somewhat. But if you Google nursing homes in Lexington, you are going to get things that are not nursing homes. And so it is much better to, instead of Google, go directly to the Office of Inspector General's website to get an official list of those facilities. It tells you exactly what the licensure of that facility is and how many beds there are. This got cut off, but you would go here, you could look at assisted living communities. You could download it as a PDF or by an Excel sheet. Then if you download it in Excel and you're good with Excel, you can manipulate the columns so that it shows you what's in Fayette County or what's, in Boyd County or wherever you're wanting to look. It shows you what level of assisted living it is, whether it's basic health or dementia care. Then there's the family care home list. Below that is the long-term care listing, which is the nursing home listing. The long-term care listing is much more complicated. So if you wanted to call and talk to me about it, we'd be happy to talk to you about it. But you can also, if you're looking specifically for nursing homes, you can go to medicare.gov/nurse or NH compare or nursing home compare to see nursing homes near you. You would just put your zip code in and tell them you're looking for a nursing home. You can look up a specific one, or you can just hit search and see what's in the area. This pulls directly from the Center for Medicare and Medicaid Services data. So it pulls from the surveys that the Office of Inspector General does of those nursing homes. So it tells you what their star rating is. It tells you if they take Medicare or Medicaid. It does tell you a bed count, but it doesn't tell you how many beds are Medicare versus how many beds are Medicaid. That information, if you're looking in Central Kentucky, I can help you with that information. The OIG directory kind of has that information, but it's hard to read. Um, so, but I can help you with that. Um, as a slight caveat, if you read the Herald Leader, you know that Kentucky is terribly behind in surveys um, of nursing homes. And so some of this data is really old. There are some nursing homes that haven't been surveyed since like 2020. And so OIG is under a lot of pressure to get in these facilities and update the surveys, but it is still dated. And so the most important thing that you can do in deciding where to go is visiting that facility and going in and looking around and not being fooled by a beautiful fireplace with nice chairs in the lobby, but instead looking to see what residents look like and what does the hallway smell like and what do you hear and what do you smell in the dining room. And if you visit, look for the activities calendar. Are there activities on that calendar that you think your mom would want to participate in? And number one, out of anything that you could consider, how often can you go visit? Because if it's next door to work, if it's, 5 minutes from home, that weighs more than most other things that you could consider. If it's 45 minutes away, but it's beautiful, you could do that. But the most important factor in getting good care is having somebody regularly visit. So I always tell people pick somewhere that you can visit or your family can visit as often as possible. So, and that then brings me to getting quality care, how to ensure somebody gets good care. Number one, sign up for our email list so that you can keep up with what we're doing. I will say we are a nonprofit, so we do send out fundraising emails on occasion. You do not have to make a donation to get our information. We do a monthly newsletter where we tell you what we've been up to, things to look for in the legislative session, things that you can do to advocate for long-term care residents yourself. But that's a great way to keep in touch with us. Signing up for the Consumer Voice is also a great way. They are a national group. They are more sophisticated, so you can sign up for just specific things that they do. They have like a weekly newsletter called The Voice, or maybe a monthly newsletter called The Voice that you could sign up for. That's really great. They have a ton of information for family members, like this avoiding drugs as chemical restraints. We got rid of residents being tied to chairs in nursing homes, but now we have drugs that basically make them sleep all day. And so that's the next big campaign, basically, is trying to make sure that residents are not put on antipsychotics that make them sleepy instead of, somebody making sure that if they like to walk, they don't wander into other resident rooms, or if they like to walk, they're not walking out the door. So sign up for that email list. And then get to know us. Call us and let us know that your loved one is there so that we can visit and give them a list of the rights they have. Visit the facility regularly at different days, different times. Learn about resident rights, exercise those rights, learn about APS and OIG. If you go into the nursing home and there's a sign that says that the state regulatory agency is there, ask if you can have an interview with somebody so that if you have concerns, so that you can report them. If you are there and there are problems, or if there's not, join a family council or create a family council. To find your Kentucky Ombudsman, go to our website and click Find an Ombudsman. If you have a loved one out of state, you can find the Ombudsman program by going to the consumervoice.org/get help. It's now buried. It used to be a really easy link to get to, so I just gave you the direct link, and then click on the state. And a lot of these states have like specific county breakdowns that you can see who you need to get in touch with directly. And then I will wrap it there so that we can get to questions. But you're welcome to email me. Really, if you have somebody in the Bluegrass that you want to talk about, Alice is the district ombudsman for this region, so she'd be the best person to talk to about a specific situation. But I don't mind to talk to you as well. She just might be more readily available. So, or go to our website and you can read up on some of these things as well.
Whew,
So, Terry, I'm ready for rapid fire
that
questioning in the
that
next few
was a
minutes.
lot of great information. Thank you, Denise. Wow. I mean, it's like, oh my
Well,
gosh.
thank
Anyhow, we do have
well,
a
thank
few.
you guys. It's always nice to be here.
Oh, yeah, look at this. Oh my goodness. Thank you so much. That was so informative, so great. So first of all, can we get a copy
Send that
of
here.
your PowerPoint? Is
Yeah,
that
of course.
possible?
I'll send this to you after we get off here.
Okay, great. So Denise will send it to me and I will send it out to everyone who's registered for this today's presentation in a follow-up email, probably this afternoon, maybe tomorrow morning, just kind of depends on how things go, but you will get a copy of this. I was trying to take notes and I thought, oh, forget it. I hope we can get a PowerPoint copy. There's just too much going on.
I
Um,
can't talk slow enough. I don't know if you all know Dave Emerson, who does one of your Ollie classes on elder law, but I do a session for him each year, and he every year is like, I tell you every year to slow it down. I'm like, I cannot help myself. I just want to
no,
tell everything.
but there's just so much information to know, and it's all stuff we need to know, especially if our loved one is in a care facility. Okay, so there was
Yeah.
a question. My parents live in a different state. Would you recommend going to the state inspector's general website for long-term care information? But you also gave the ombudsman through National Voice, so that's
Yeah.
another idea.
Yeah. I would say if they are currently at home, then I would look up the ombudsman program for that area and see if you can talk to them about, what the long-term care settings are in that state. I will say there are entities that will tell you that they will help you place somebody, like if you're out of state, you can call this service that will do it for you. And you just have to be careful with that because some of those services are basically in contract with different facilities. And so you're calling them to help them place your mom somewhere and they get money for placing your mom at this facility versus that facility. So just be careful because an ombudsman program, I don't get money from anybody except for the state government, the federal government, and grants that I write to provide this information. I don't get money from the nursing homes, the personal care homes. So we're non-biased. We're not allowed to say don't go here or don't go there or definitely go here. So I would recommend trying that first. The inspector general or the health service, whoever the survey agency is, um, it's my experience that they're not always very good at communicating with consumers about things because they're very much more entrenched in like a open records, bureaucracy type situation where they're not having candid conversations.
Got it. Okay, thank you. I love that.
Yeah.
All right, let's make sure that we have, okay, so we got the state inspectors. There's very helpful over there. Sorry, I was late to presentation. What if your parents want to stay together, but one needs assisted living and the other does not?
Well, assisted living has no requirements to live there. So, because it's all private pay, you could have somebody living in assisted living who doesn't need assistance with daily activities. And as far as I know, so one of the things that the idea behind modernizing the assisted living regulations was that you could have your building be an assisted living basic health building, but then you could offer to somebody, that I only want the social model services. But you have to license the whole building as basic health. So it's still kind of confusing, but in terms of assisted living, you could certainly have, and a lot of assisted livings are built so that you could have a partners living together, spouses living together. So you could definitely have two people live in an apartment in an assisted living where one needs assistance and the other does not. And it would just simply be kind of talking to that admissions person about that and negotiating what the kind of the cost would be, the lease and the contract and all of that. Um, but that wouldn't be an issue at all. Once one person needs nursing home level of care and the other one doesn't need care, or maybe only needs assisted living, that's where it might become challenging. There are some facilities like in Lexington, you have the Willows has assisted living wing and nursing home wing. So there are some people who have one partner in the assisted living wing, one partner in the nursing home wing, and then they eat together, they visit each other, they hang out in one person's room. But that would be kind of a different uh setting, and those are not as common to find the facilities that have both settings in the same building.
All right. Hope that makes sense. Yeah. Next question. Well, it's about an elder law on campus. We do have the legal clinic here on campus. It is for low income, but I don't know if that's exactly going to help you with the documents you have. If you reach out to Hazel, I put her email in the top of the chat box. She can send you a list of elder law attorneys in town to help you with those documents. And the last question we have is, I am researching about the long-term care costs. Can you recommend some place to refer to on long-term care costs? Is
Well,
that public knowledge?
it's so there is somebody that used to publish a little something. It was really like just a very small infographic. And I can't remember who that was, but um it's kind of difficult to find because it's mostly, if it's not nursing homes. So nursing homes, if you how about this? I will try to find something and email it to you, Terry, to include in the email that you send out with my PowerPoint and the recording. But really you could it's really difficult to find anything about anything that's not
Yeah,
nursing home. To find something about assisted living or I could email you the other levels of care, but assisted living is very difficult because it's all private pay. And so we've had some facilities that are kind of like a flat fee, and then we have a lot of facilities that are moving to a la carte, that are
mhm,
kind of like, if you need this, then it's an additional cost per month. And if you want that, then it's an additional cost per month. And the way the reg is written, there's really nothing saying that they can't do it that way. It says that they have
right,
to offer that as a service, and it says that they have to tell you what their service fee schedule is. It does not say that it has to be included in a base monthly fee.
right.
It's not very easy to kind of find, but I'll find at least the other levels of care because they're pretty, there's a pretty normal range for those.
Okay, all right, and I'll send that out into the follow-up email. So thank you, everybody,
Yep.
one, for joining us today. It's been a pleasure. Denise, this has been great. Thank you so much.
Yeah, absolutely. It's a